Hey guys, this is your Nursing School Made Easy, and today's lecture is going to focus on diabetes mellitus, and more specifically on type 2. We did a previous lecture on type 1, so again this is going to focus on type 2. And one of the things that I forgot to mention in the previous lectures is that your normal glucose range should be between 70 to 100. That'll depend on your textbook. So again, I'm going to use a reference of 70 to 100 as a normal glucose level. Now in type 2 diabetes, similar to type 1, you're going to have an abnormal insulin production. Normal insulin production. And you're going to have also abnormal or impaired insulin use. Now let's focus on some causes, and then these two will make a little bit more sense. So number one, the number one cause for type 2 diabetes is obesity. Now I heard a patient a while ago tell me that she had sugar diabetes. Okay, so again we'll call this sugar diabetes. I think this name fits very, very appropriately. Now why? Okay, let's talk about breakfast real quick. And what did you have for breakfast? Let's say, for example, you had maybe a cheese omelet, hash browns, maybe some milk, maybe some cereal. Well, cheese contains lactose or milk. That turns into a sugar. Hash browns, those have carbs, otherwise known as sugar. Milk, lactose again, which gets converted to sugar. Cereal, again, contains carbs, which contain sugar. Now this is one meal. Now let's say that you go to lunch. You have a cheeseburger. And you have some fries. And you gotta have the Coke, right? You know, maybe you're watching your diet, so you make it a Diet Coke. Maybe you have a little snack. Maybe a little pie. Now that's lunch. Dinner, I don't know, same thing. Well, the point I'm trying to make is here you're eating sugar, cheese, remember the patty, excuse me, the bun contains bread, which is a carbohydrate. Cheese contains lactose, which is a sugar. Fries, again, carbohydrates turn into sugar. Your pop contains sugar. Pie, the bread in it, the sugar in it, all contains sugar. So your body is continuously getting large amounts of sugar. So I believe the term sugar diabetes is a very, very good name for it. So, okay, this is just one day. Now multiply this times 7 days a week, 365 days a year. Your body's getting very, 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 very large amounts of sugar. Now, if your body does not require these large amounts of sugar, your body will begin to store it in your abdomen. So you'll lose that awesome six-pack that you once had. You'll start to store it around your chin, around your neck, around your triceps and your arms and your legs. Again, you will become obese if you do not exercise. Now again, because you're having so much sugar in your body, you do not have enough insulin production or abnormal insulin production. Your pancreas cannot keep up with the demand. It'd be the equivalent of taking $10 out of your debit card and make another purchase for another 10, and you're only making $50 a day. Okay, the demand is not keeping up with the need. You're eating so much sugar, and again, your pancreas cannot keep up with the demand. So that gives rise to abnormal insulin production. Now, another thing that happens in type 2 diabetes, you're constantly producing insulin because, again, these demands or these increased ingestion of sugars. So again, your pancreas is producing the insulin. Well, after a while, your body becomes a little bit desensitized to the insulin, and the insulin doesn't have an effect or the effect that it once did. Therefore, you have impaired insulin use, okay? You lose that sensitivity, so your body isn't able to, again, absorb sugar like it should, store it like it should, so you begin to have some problems. So those are our two reasons. Again, abnormal insulin production, number one, and number two, impaired insulin use. And the biggest thing, the biggest cause of this is obesity. Now we talked about this. Number two cause is, again, decreased pancreas production. Again, your pancreas cannot produce enough insulin. As a result, you will suffer from hyperglycemia. Number three, and again, I talked about this already, insulin resistance. Or again, another way to say this is decreased insulin sensitivity. Now, this is something different than from type 1. In type 1, one of the biggest complications that you will run into is something called DKA, diabetic ketoacidosis. Now, in DKA, you will typically have glucose levels between 3 to 400. Okay, that would be DKA. And again, DKA is specific to type 1. Now, in type 2, again, we have insulin production that is just not enough, or your body isn't as sensitive to it. Therefore, this is more of a gradual increase in sugar levels. Now, because again, you are producing some insulin, these glucose levels may reach up to 500 to 800. Now, this is something known as hyperosmolar hyperglycemic syndrome, or HHS. So here we have very, very different levels, very, very different numbers. In DKA, they'll be between 3 to 400. In HHS, or in type 2 diabetes, they will go all the way up to possibly 800, maybe 1,000. But again, this is due to, in part because, again, your body does produce some insulin, it's just not producing enough, or it isn't sensitive to that insulin. Okay, so that is one big difference between type 1 and type 2. Now, let's focus on some signs and symptoms. Now, these are going to be somewhat similar to type 1. Let me focus the camera here. Number 1, fatigue. Number 2, you're still going to have that polyuria that we talked about in part 1. So please go back to the lecture on type 1 diabetes, and that'll give a more in-depth explanation of polyuria. But since you are voiding a lot, you can run into dehydration or hypovolemia. So with these patients, you'd want to check their blood pressure, because they may become, they would have problems with, for example, orthostatic hypotension. You would also want to check out that heart rate, because most likely they would be tachycardic. Again, this has to do to the hypovolemia. Your heart is trying to pump the same amount of fluid, so it's going to increase its heart rate in order to meet that demand. Number 3, recurrent infections. This could be something like a yeast infection, UTIs. Number 4, prolonged wound healing. And this is a very, very big one. Because again, if this is a surgical patient, they must know that their wound or surgical site is going to take longer periods of time to heal. Also, you're going to want to assess that wound more times. You're going to pay closer attention to it. Signs of infection: redness, swelling, discharge, pus, fever. Number 5, visual changes. So when these patients go to the optometrist, one of the things that they'll do is they will dilate the pupils, look at the arteries in the retinas, look for some type of retinopathy. Okay, any visual changes would be a sign of retinopathy. Blurred vision, things like that. Number 6, headaches. 7, obviously hyperglycemia or increased glucose levels, blood glucose levels. 8, somnolence. Number 9, aphasia, difficulty speaking, difficulty with talking. 10, hemiparesis, difficulty with moving maybe the right side of the body or the left side of the body. Now, these are going to be signs of HHS. These would indicate very, very high glucose levels, or 5 to 800 region. Okay. Now, also, these kind of mimic signs and symptoms of, for example, a stroke. Okay, so pay very, very close attention to your patient. Are you noticing any altered mental status? Now, what are some complications? We talked about the complications in the lecture on type 1 diabetes, so I'm just briefly going to mention them. Number 1 was hypertension. Number 2, stroke due to the hypertension. Number 3, nephropathy. Nephro meaning kidney. This would be like some type of chronic kidney disease, renal failure. Number 4, atherosclerosis. Number 5, erectile dysfunction. In men, of course, peripheral vascular disease. Now again, this would be very, very important if, for example, they have some type of wound in the extremities, because again, that would decrease wound healing time. There's decreased circulation to that area. This would only increase due to, again, the atherosclerosis. Number 7, coronary artery disease. Number 8, retinopathy. Again, this would be due to the hypertension. The nephropathy or the renal failure would be, again, due to the hypertension. Number 9, gangrene. Again, this would have something to do with the peripheral vascular disease, which again could be caused by the atherosclerosis. So again, with diabetes, you just have so many complications, guys. So this is something that you want to be very, very familiar with. Educate your patient. It is your role to, again, educate your patient on the complications that can occur. So please tell them to monitor the glucose levels very, very carefully. A lot of times with these patients, they may be non-compliant. And a lot of times I do think that it is because they're not fully aware of all the complications that can occur. And it is, again, our job as nurses to inform them. Because again, some of these complications, the gangrene, they could end up with something like an amputation. The coronary artery disease could end up with something like a heart attack and a MI, myocardial infarction, again, heart attack, stroke. We'd end up with paralysis. So again, there's so many complications. Now, let's get into some drug use. That sounded kind of bad, but drug therapy, that sounds better. Number one, some of the medications that you may use are the sulfonylureas. I can say it in my mind, I just can't pronounce it right. Sulfonylureas. Examples of this would be like glipizide, sulfonylureas. There, now I said it. Glipizide, glyburide, glimepiride. Now what these do, these will increase insulin production. And these increased insulin production. Now, as a result of increased insulin production, you can have hypoglycemia occurring. So with these patients, you always want to, again, assess their glucose level. So you do finger sticks. Yes, the therapy may be working, but it might be working too good, and you would cause hypoglycemia. Now, with these medications, you must inform your patient that weight gain will occur. Number two, the meglitinides. Something like Prandin or Starlix. Now these will also increase insulin production. These will also cause weight gain. But the difference between these two is that these are less likely to cause hypoglycemia. Okay, again, these are less likely to cause hypoglycemia. Now, with these patients, you want to make sure that you tell them to take the medication 30 minutes before eating. Okay, again, take it 30 minutes before eating. If they do not eat the meal, do not take it. So if they skip a meal, they will not take this medication because again, it will make them hypoglycemic. So again, take 30 minutes before eating and do not take if the patient skips a meal. Number three, the biguanides. Something like metformin. You've heard me talk about this drug before, or otherwise known as glucophage. Now, typically, this is the number one choice. Typically, patients will be started on this first. Now, this drug causes no weight gain. that's one thing that is very, very different. Now, the other medications, increased insulin production. This causes increased insulin sensitivity. So your body's still producing the same amount of insulin, but it is making your body more sensitive to it, okay? Again, increased insulin sensitivity. Now, one thing to know about, or a few things to know about metformin, is that you will not give metformin to patients with impaired renal function or patients with kidney disease. Okay, again, you do not give these medications to patients who have impaired renal function or, again, some type of kidney disease. Number two, you will not give these medications, you will not give metformin, otherwise known as glucophage, to patients who have excessive alcohol intake. Number three, you will withhold metformin for patients who are about to undergo some type of radiologic procedure, or if you know that they're going to have surgery, for example, some type of cardiac stent placement. Why? Well, because they're going to receive most likely iodine contrast. Iodine contrast is hard on the kidneys. This medication is also hard on the kidneys. So again, you will tell the patient to stop taking medicine day of and withhold for 48 hours post. Okay, so if a CT abdomen, pelvis, CT chest with IV contrast is ordered, you will tell that patient to not take the medication that day, and you will tell that medication to hold it for 48 hours. Okay, that is very, very important, so make sure you know that for the NCLEX. NCLEX might ask you something, which of the following would you tell the patient if patient is scheduled for some type of cardiac stent placement? Well, again, one of the biggest things that you would tell them is to, again, stop, hold metformin, and you'd hold it for 48 hours. Number four, the alpha glucosidase inhibitors. These are, for example, like Precose or Glycet. Now these, you will tell your patient to take it with the first bite of each meal. Five, drugs like Actos or Avandia. Now again, these are given to patients with insulin resistance. So again, these increase insulin sensitivity. Now the problem with these medications, or Avandia more specifically, is that it does increase the risk of MIs and stroke. So this is very, very important information that you want to tell your patient. This does increase the risk of MIs and strokes. Therefore, you will not give this medication to patients with heart failure. Okay, so you want to make sure you ask your patient very, very, very thorough history, medical history. Do they have any type of heart failure? If so, they cannot receive Avandia, because again, it makes it more likely for them to suffer from a heart attack and a stroke. Now, number 6. In a hospital setting, they will most likely also be put on some type of insulin therapy. Now for the insulin therapy, different types, please go back to the lecture on type 1 diabetes. But these patients may also be put on insulin therapy, especially if they're about to go to surgery. If they're going to go to surgery, patients will be put on NPO status. You will again always monitor their glucose levels, and if it is elevated, they will most likely again get insulin therapy. Now, I forgot to mention this in the lecture on type 1 diabetes. If you're going to be giving insulin therapy, you can either give it sub-Q or IV. Typically, if you give IV insulin, it'll be in the ICU, okay, because you have to monitor very, very closely. If you give too much insulin too quickly, you can cause hypoglycemia. So typically, you will give sub-Q. Now, you can give the insulin in the abdomen, in the back of the arm, or in the arm region. You can give it excuse me, in the thigh and in the buttock region. Now if you wanted to take the fastest effect, you will give it in the abdomen. Okay. Another thing to tell your patient is, if they are an active patient, let's say they're going to go jog, they're going to go run, you would tell them to avoid putting it in the thigh, because again, they begin to move, that muscle is going to have increased circulation, so the insulin will have greater effect, or excuse me, it will take a faster effect. So again, you would tell them to avoid exercising that area.